Welcome back to another episode of the Oncology Brothers podcast in our ongoing series of new FDA approvals. Yes, we've seen a few already in 2025. We just covered cabozantinib recently based off cabinet study in neuroendocrine tumor. And today we're covering Niagara Trial in resectable muscle-invasive bladder cancer. For this, we're joined by the lead author of this trial, Dr. Tom Powles, a GU medical oncologist from Bart's Cancer Institute in England. Tom, you were with us to discuss EV302, which resulted in doubling of OS for metastatic bladder cancer with use of enfortumab and pembro. And here we are again with another approval and change in our standard of care treatment. Thanks for joining us again.
Thank you for inviting me.
Welcome to back-to-back successes for you, your team, and importantly, for our patients. Congratulations. Prior to Niagara Trial, our treatment for unresectable muscle-invasive bladder cancer has been neoadjuvant chemo with cisplatin backbone followed by surgery. Now we have Niagara Trial with the use of immunotherapy upfront followed by surgery, along with chemo, and then also adjuvant Durvalumab. On March 28, 2025, Durvalumab plus chemo was approved for resectable muscle-invasive bladder cancer. Before we touch on the study design and talk more about the study itself, being a Canadian, and we both live in upstate New York and are very close to Niagara Falls, I have to ask you this. Why the name Niagara?
Okay, let me tell you. So we started the bladder cancer series with Durvalumab named after rivers and water areas, to be fair. We have the Nile trial, the Danube trial, the Biscay trial, for example. We have the Volga trial, which has become quite controversial, of course. And finally, we have the Niagara study. There are others as well. There's the Potomac trial. Now, I've got to tell you, the Niagara study is the shortest river. It's only 40 kilometers long. And I don't know if we named it after the river or the falls. I'm guessing it was the falls. So strictly speaking, it should have been named after a river. But it has been the most positive of all of those, which just shows you that you can't judge a book by its cover.
Indeed. And just for our American friends, 40 kilometers will be 24.8 miles. All right. Can you start us off with the study design and also touch on the cisplatin dosing for the patients with renal dysfunction used in Niagara Trial, please?
Yeah, the neoadjuvant chemotherapy prior to cystectomy is associated with about a 5% improvement in overall survival. It has to be cisplatin-based, and Gem-Cis has become the standard of care, although other regimes are also used in that neoadjuvant space. But there's no clear consensus on the best regime, and for that reason, Gem-Cis, which is the most widely global regime, was chosen. We chose 4 cycles. There is also a debate about the number of cycles. Some people have given 3 cycles rather than 4, and indeed some trials have 3 rather than 4. There's some trials which give 6 cycles. But 4, if you go around 200 centers around the world and try and do a big global trial, it's pretty much agreed 3 is too short for many centers. So 4 were chosen. The global community feels that any platinum-based chemotherapy is better than none. If you look at the uptake of neoadjuvant chemotherapy 20 years ago, only about 20% of patients were getting it. We've increased that percentage now. So the majority of patients from a global perspective are giving neoadjuvant chemotherapy. And what I say to people is, I don't really mind which neoadjuvant regime you give, but it's better to give it than not give it. And I hope we've won that battle. Adjuvant chemotherapy has never had as robust data, and carboplatin has never had as robust data. This trial is the first of a series of perioperative immune therapy trials. It's not a neoadjuvant immune therapy trial. It's neoadjuvant chemotherapy, but perioperative immune checkpoint inhibition. 4 cycles given beforehand with the chemotherapy, and then the remaining of the year, 8 cycles given afterwards. Some people say, why isn't there a third arm only exploring that neoadjuvant space? And the answer to that question is, this is a 1,000-patient study with survival powered for that. It's crucial we hit survival in these trials. We don't think other endpoints are fabulous. They're okay, but not fabulous. You can't really do a much smaller 2-arm trial. You have to do, for survival, you need about 1,000 patients. We've never done a 1,000-patient neoadjuvant trial before, anywhere near that in bladder cancer. I was involved in some of the EORTC studies where we only recruited 200 or 300 patients and closed early because of slow recruitment. So to put a third or a fourth arm with 2,000 or 3,000 patients didn't seem practical at the time. So this doesn't answer all of the questions. But what it does tell us is early immune checkpoint inhibition saves lives and is associated with a significant survival advantage. There are other correlative endpoints, pathological CR, circulating tumor DNA, that we can talk about in a minute. Essentially, we included patients who were classic muscle-invasive bladder cancer, T2 to T4A. We included a small percentage of patients with N1 disease. I would have liked to include more of those patients. At the moment, many of those patients are having surgery and being included with neoadjuvant chemotherapy. We allowed the creatinine clearance to go down to 40. Historically, there's always been a debate about the level. If you split the dose of cisplatin and give day 1 and day 8 cisplatin, you can go down to 40 mils per minute. And that's what we did in this trial. 20% of patients had split dose cisplatin in this study. We picked our endpoints, and this is important, dual primary endpoints of path-CR and event-free survival. We had overall survival with alpha control as a secondary endpoint. There was an interim path-CR analysis that was not positive. It was an early analysis. Not all of the patients were included in that analysis, and that was not positive. The first endpoint that read out was the significant and positive event-free survival. When we retrospectively look back on path-CR with all of the patients, that would have been positive too.
Tom, thanks for touching on that. And again, a few things to reiterate. Cisplatin cannot be replaced with carboplatin in these settings. We know that cisplatin is superior. And out in the community, we're getting very comfortable with this sandwich approach of peri-op, post-op immunotherapy. We've been using this for non-small cell lung cancer, triple-negative breast cancer, and now in bladder cancer. And we're actually awaiting trial to be read out for gastric cancer as well, Matterhorn study. And you touched on this idea of this third arm. We'll take a dive into the results. The reason why we all continue to ask for that third arm is we still don't know how much is immunotherapy buying us in these post-op settings, especially if you have complete pathological response. Tom, why don't you walk us through these findings and then let's touch on some of these nuances.
So the overall survival, there was a significant overall survival advantage with a 25% reduction in the risk of death. The curves go apart at about 4 months and they stay apart. The hazard ratio of 0.75 is statistically significant. The landmark 24-month OS is 75% versus 82% for the combination arm. So a 7% increase in OS at 2 years. The curves go apart and they stay apart. There was also a pathological CR rate of 37% and 27%. The primary endpoint, event-free survival, hazard ratio was 0.86. It hit 2 of those endpoints, and the third endpoint showed a 10% delta in path-CR. When you look in detail at path-CR, we've done some subsequent analysis, and we've shown it doesn't matter if you had a path-CR or not. The Durvalumab arm tracked above the standard arm. 2 things about path-CR. It's not a perfect endpoint. In the control arm at 2 years, 15% of patients relapsed, even if you had a path-CR, just showing it's not perfect. And then there was a 7% increase from event-free survival in those patients who had the addition of Durvalumab. And in those patients who did not achieve path-CR, only 50% of those patients remained event-free. And again, there was about a 5% increase in the addition of Durvalumab. What this tells us, which I think is relevant, is number one, path-CR is not a perfect endpoint. If it had been perfect and no one would relapse, you could say, well, maybe if no one's going to relapse, you don't need to give the Durvalumab, then you've cured them. But you haven't. 15% relapse and the Durvalumab arm do that. So it doesn't resolve that issue around path-CR. We have to keep going. I think it's also worthwhile saying in the subset analysis of these 2 trials, in the forest plot analysis, the benefit was across broad subgroups of patients. So whether it was pure urothelial or had a component of other non-urothelial components to it, whether it was T2 or it was more advanced, whether it was split dose or non-split dose, geographical regions, both for EFS and OS, there were broad subgroups, both benefit against broad subgroups of patients. And then finally, And maybe most relevant, can you give the combination safely? What we discovered surprised me a little. Number one is more patients in the Durvalumab arm got surgery than in the control arm. One of my great fears was that as we gave therapy to patients, we may get some immune-related toxicity, and that immune-related toxicity might make the surgery more complicated. We could have lots of patients on steroids at the time of surgery because of immune-related adverse events. And we may delay surgery because patients recovering from these immune-related adverse events. And Matt Gowski presented the PathCR data very nicely at ASCO GU, and Jim Cato at EAU just presented the surgical safety data, which showed that there were no increase in delays. There were more surgeries in the Durvalumab arm. There were no increase in surgical toxicity or adverse events by CTC in the neoadjuvant period. And there were no more treatment-related deaths or post-operative complications. So number one is that it's improving survival. Number two is it's not having a detrimental effect on the incidence or performing surgery.
Thankfully, we are not compromising any surgical outcomes here. When it comes to side effects, Jem says we're very comfortable with what to expect. Durvalumab, again, out in community, we use this day in, day out. We're very comfortable with that. When we're combining Jem says Durvalumab, anything unique that we have to worry about? Can you just touch on the side effects that we're seeing in Niagara Trial?
So let me tell you what I think about this. I don't think CTC criteria were designed to assess adverse events associated with immune therapy. With immune therapy, you can get the weird and the wonderful. You can get interstitial lung disease, you can get chronic colitis, you can get pneumonitis, you can get other adverse events, endocrine, neurological, and cardiac adverse events. In this trial, we said if you're getting into trouble with immune therapy on cycle 1, 2, and 3, don't keep pushing it in. The important thing is you get the patient to the surgical operation safely. If on cycle 2 you need steroids, you might not want to give cycle 3 and 4 of immune therapy. You want to get the operation done, do it safely, and then maybe reintroduce the immune therapy in the adjuvant phase. The important thing is not to be pushing, and this is true for platinum-based chemotherapy. If you get really bad neutropenic sepsis on cycle 3, I wouldn't give cycle 4. Let's not compromise. Give the patient some time off. Get them back to baseline. If you're saying, what would I be encouraging people in the community to do? Don't force in the immune therapy if you're running into trouble. On cycle 4, if you've got transaminitis grade 3 on cycle 3, and if the patient's still got a grade 2 transaminitis, if you push in cycle 3, you're going to end up delaying the surgery. So it really is classic good medicine. When being pragmatic about problems, prioritizing the important things, in this case is the surgery, and making sure you're getting that patient to the surgery effectively. Because, our surgical colleagues, we have to work in parallel with them, and they'll stop referring us patients if each one arrives on 60 milligrams of prednisolone with a grade 3 pneumonitis.
Thanks for covering that, Tom. Rahul, as you alluded to, not just here, but also in breast, lung, and now in gastric, we will be utilizing this peri-op approach. When using post-op IO, the question always is, which is that patient who is deriving this benefit of post-op immunotherapy? Tom, outside of clinical trials, any role of ctDNA to dictate who should in fact get immunotherapy in adjuvant settings?
I don't know the answer to that question. I could talk about it for a long, long time because I like to meander when I don't know the answer to the question. Let me tell you what I think at the moment. I think ctDNA is going through a really rapid evolution. I can tell you from other neoadjuvant trials, Abacus, Tombola, and other adjuvant trials in Vigor 11, that the proportion of patients before surgery who are ctDNA positive, it's about 60%. So it's quite a high proportion pre-surgery. Now, that doesn't necessarily represent micrometastatic disease. It may just represent the primary T2 or T3 tumor. Post-surgery, it's about 10% of unselected patients. But if you go for high-risk patients, such as in Vigor 11, that goes up to about 40%. So if you pick the high-risk post-operative patients, about 40% are ctDNA positive, about 60% at baseline. Immune therapy alone is associated with about a 20% clearance in ctDNA, and chemotherapy, we think, is associated with about a 30% clearance. This is predominantly with the Natera technology, which is the informed technique. There are other techniques which have less robust data. If you are ctDNA negative post neoadjuvant immune therapy and chemotherapy, does that mean you can stop therapy? Well, there are two parts to that. Number one is it might be the immune therapy that's actually cleared your ctDNA, because we know that's about 20%. If that's the case, 3 months feels too short for me. In metastatic disease, you wouldn't give 3 months of immune therapy. In my world, I think you get one good go at immune therapy. If I had a patient who cleared their ctDNA, I would say we need to keep going to consolidate this benefit. I think 3 months of immune therapy is too short. One of the key questions will be, what about those patients that don't clear their ctDNA and remain positive? Should we keep going, or does this define treatment failure? And that's also an interesting issue. My gut feeling is if you remain ctDNA positive, we should keep going with this. But you might say, well, if they remain ctDNA positive, they're going to become radiological positive. We know that ctDNA positivity tends to predate radiology positivity by about 4 to 6 months. So I would keep a really close eye on that patient. And then there's an issue about whether they should be given EV pembro, more immune therapy, or EV by itself. Right now, I don't know the answer to that question either.
ctDNA is a moving target. The data is intriguing, but out in the practice, we should not be using this to dictate our treatment. The standard of care as of now should be all comers getting immunotherapy if there's no other contraindication. And whenever we're keeping these patients on immunotherapy longer, we have to manage those side effects.
Well, it's a fine balancing act. Tom, before we close, this we will see in community or academic setting. If this patient was to progress or recur, are you going to use enfortumab with pembro or enfortumab alone? How is that sequencing going to look like if the patient is on durvalumab in post-op setting or has completed durvalumab?
I've given this question a great deal of thought, and there isn't any data at the moment. And I've got two answers, if I may. One is a scientific answer, and the second is a pragmatic answer. The science that's available to us as it stands suggests immune therapy patients or patients who receive immune therapy have one good go at responding to it. We haven't shown that sequencing PD-1 inhibitors, or indeed LAG-3, OX40, and CSR, we haven't shown that in nivolumab refractory disease or that other immune therapies suddenly work brilliantly. It looks like the tumors are predisposed to either respond or not. Drugs like atezolizumab cause an immune infiltrate, but that seems to be associated with a potentially response, but it doesn't seem to be associated with when you would give it a second time, you get that occurring again and again. Number one. Number two is we've done randomized trials in kidney cancer where we've re-challenged with immune therapy, and it's done absolutely nothing. This principle of giving it a second go doesn't make a lot of sense. There is the caveat in the adjuvant or the perioperative setting, if a patient was to relapse a year or two afterwards, it would be reasonable for a clinician to say that's different from the metastatic trials that you've done. It may be that they were always a responder and needed a longer period, and we're more comfortable giving 2 rather than 1 year of immune therapy. So I'm happy to entertain the possibility if there is a gap between immune therapy. But if it's within 6 months, you're still on immune therapy as far as I can see. And so I'm not super keen on re-challenge. Let me, though, come to EV pembro. There are people who believe that EV pembro has a synergistic interaction. We haven't seen CR rates of 30% before. We haven't seen OS of 36 months. And with so few attractive options remaining for these patients, particularly in Niagara, who will have had platinum-based chemotherapy and immune therapy, the thought of going on to something like single-agent taxane therapy is really unappealing. So clearly, EV for me is definitely the right treatment. The question is that addition of pembro going to be associated with something unusual that we don't know? Is the EV disrupting the tumor microenvironment and letting the T cells in? We haven't shown that's not the case yet. I've got a group, Rumigos group, that we do with my friend Brian Rooney, and we've generated a scoring system where we've asked around 30 experts around the world what they think of re-challenge with EV pembro. The majority of experts are comfortable with it. But I think that's not because of the luxury of choices in this environment. It's because you're almost in the last chance saloon here. And I think people feel that patients who have relapsed disease, having a go with even pembro makes sense. Another big question will be, EV Pembro will move into the neoadjuvant setting. And when that happens, what do we do next? And I tell you, that's a podcast for a different day.
This is all data-free zones. How we come up with sequencing is important because patients living longer. In the last year, we've seen bladder cancer overall survival doubling in metastatic disease, thanks to your study. And now in muscle-invasive resectable disease, we're again seeing improved pathological complete responses, improved overall survival with use of immunotherapy and chemotherapy. Tom, thanks for taking the time to cover Niagara study with us today, which has led to the approval of Durvalumab with chemotherapy in resectable muscle-invasive disease. For our listeners, let us go over a quick recap from today's discussion.
Today, in our discussion with Dr. Tom Powles, a GU medical oncologist and the lead author for the Niagara Trial, we had a chance to break down the recent approval of Durvalumab and chemotherapy in resectable muscle-invasive bladder cancer. We touched on improved overall survival of 82% versus 75% at a 2-year mark with Durvalumab and cisplatin-based chemotherapy in combination, and then continuing Durvalumab for completing that total of 1 year after surgery.
Right. Not just today, but even during our non-small cell lung cancer and triple-negative breast cancer, we've touched on this sandwich approach and use of immunotherapy in resectable cancer. It remains unclear if all patients are deriving equal benefit from post-op immunotherapy, but the given clinical trial design, this should be part of our treatment. Thankfully, we're not seeing significant toxicities with the combination of Durvalumab when we're comparing this to chemotherapy alone. Given this recent approval, Durvalumab with cisplatin-based chemotherapy should now be the standard of care treatment for resectable muscle-invasive bladder cancer. Thanks for joining us. Make sure to check out our other conference highlights, FDA approvals, and talk check discussions. We are the Oncology Brothers.